So we have our image. It looks great. We've mastered image acquisition and we're feeling comfortable there. Now moving forward, starting to dig into more of the meat of what we're seeing on the screen. Talk to me about image interpretation and what are we looking at?
With a good image quality, you already got probably the most valuable information, which is lumen, right? So you have that perfect 75 millimeters of well-segmented lumen on the pre-PCI and on the post-PCI. So that's already like done. Number two, the most common question that you want to know is within your lesion, what kind of plaque, what kind of tissue you are dealing with, right? So the big three are fibrotic component, lipid, and calcium. What I'm gonna suggest is you're beginning your OCT journey. Remember that there are two factors that help you qualitatively identify these tissues. One is what we call attenuation. So the laser hit the plaque and start losing energy and cannot penetrate the plaque anymore. Remember when we were comparing with IVUS, the tissue that has the most attenuation is lipid, right?
Right.
So OCT cannot penetrate lipid. Great, because now you have a signature of what is lipid, right? So attenuation is what is going to identify lipid. If the signal can penetrate and is bright and is homogeneous, that's fibrotic. If the signal can penetrate but the brightness is less, this typically would be calcium. So calcium comes with less intensity tissue, high penetration because you don't lose energy penetrating calcium, and very well defined borders, the typical calcium, right? We can talk about subtypes of calcium now, if you wish.
Sure. I was going to say calcium, I mean, that's the enemy of the interventional cardiologist always. So with OCT and calcium, what do you look for and how do you assess calcium and how does the software help you assess calcium?
Right. I agree with your statement. I think calcium is tissue that we are always more concerned with in terms of its presence might indicate limitations on expanding your stent, essentially, right? Or getting equipment down. So calcium you identify in a historical perspective on IVUS as quadrants, right? Because remember, the ultrasound cannot penetrate calcium, so the only thing you can talk about is 1, 2, 3, or 4 quadrants of calcium. With OCT, you're gonna have these quadrants or angle of calcium, but you're also gonna add another dimension that is depth of calcium or thickness of calcium. So on ultrasound, the software is going to spell out on the screen maximal thickness of calcium and the angle of calcium, right, along every single cross section we have. So you can use that information. You can qualitatively assess the milieu in terms of calcium distribution, and then decide if that amount of calcium require any sort of lesion preparation in order to anticipate a good stent expansion. But specifically on the image interpretation, I want to highlight that there is a particular type of calcium that lose the fibrotic component on top of it, and now that calcium become exposed. That's what we call the nodule of calcium, and that calcium is a subtype of calcium that is not that common, but you might misinterpret that calcium because of a high attenuation as if it was thrombus or lipid. Okay, so how you go by this is utilizing more than one cross-section. So typically you would have adjacent to that nodule of calcium protruding to the lumen, a classic calcium that has well-defined contours and good tissue penetration.
So normal vessel, tell me, what does a healthy vessel look like on OCT?
A normal vessel would be a vessel in which your lumen contour is very close to the adventitia, right? So the adventitia is this, what I describe like a onion skin pattern. In between the adventitia and the lumen, you should have 3 layers. First layer, bright layer, is the internal elastic lamina. Then you have a dark layer that is the media, and a third layer, EL, external elastic lamina. Often you don't have all these 3 layers, so that's where I prefer describing a very little distance between lumen and the adventitia, right? That's a normal vessel.
Yeah, so going back to some of the AI features that are in Ultron 2.0, what does this software do that can help you identify where a healthy segment in the vessel may be?
Yeah, so the software is going to pinpoint angles of normal vessel and actually color code even for you on the L mode areas that would be considered good landing zones of a healthy vessel. It's a bonus, but you're rapidly going to acquire this ability to identify normal vessels by yourself. Unfortunately, not always, or actually, it's unusual to have perfectly normal vessel on both proximal and distal edges. So you're going to need to scan the vessel, and that's why it's important to start your pullback at least at 10-15 millimeters distal to your lesion, trying to look for the best landing zone. But we're gonna dive a little bit deeper on procedural planning in another chapter.
Sounds good. Since you mentioned thrombus when you were talking about nodular calcium, help me understand a little bit more how OCT helps us differentiate between red and white thrombus.
Absolutely. Probably would start just with the statement on how sensitive OCT is to detect thrombus is pretty amazing. There is a paper that compare OCT versus angioscopy, which would be considered the gold standard to detect thrombus. And in 100% of the case, OCT could identify thrombus to the order of 10 microns. So if OCT doesn't see thrombus, that means that there is no thrombus, right? This is going to be more impactful when we discuss niche of OCT application like ACS, population, etc. But back to your question on the aspects of a red thrombus and white thrombus, the way I describe is that the red thrombus is the organized thrombus that is cellular rich. So think about red thrombus as you are not doing a good job displacing blood, because it is blood. It's just more organized. So, and you know how the light behaves against blood, it attenuates. So red thrombus come with a high amount of attenuation, and that's what you're gonna see on your image. You don't see past the red thrombus. White thrombus would be the platelet rich and less cell rich, and then you can see through it, right? And what's the relevance, the clinical relevance of this? We're gonna again talk on the ACS chapter, but it's very easy to differentiate between the two.
So we've started to scratch the surface on understanding what we're looking at from a morphology perspective, but how do you take all of that information and apply it to your workflow when you're doing a procedure?
I think it's very fascinating for me to think, at least my generation of interventional cardiology, we grew up with the idea of intravascular imaging, namely IVUS, post-stent. With OCT, we learned early on that a lot of the added value of this method precede the stent. So our workflow is really to emphasize OCT pre and most of the time post, but put a big emphasis on the OCT pre. More than a decade ago, we had an all-comers study, single center that we did, in which we clearly demonstrate that there is more change on procedure planning comparing angio decisions versus OCT when the OCT was done before the stent is in place than post-stent. This was followed by Illumin 1 trial that demonstrated the same thing. You gain more changing in procedure planning with OCT pre than OCT post. And then recently revalidate for the third time with the Light Lab initiative. Similar findings, very consistent. When the operator does OCT before a stent is in place, there is an impact on about 80% of the procedures. Some change can be shorter stent, longer stent. Initially, I thought I needed to do atherectomy. Now, I don't need atherectomy. I thought that I could direct the stent, but I actually need atherectomy. So all these questions precede the stent. And in 80% of the case, if you commit with a strategy angio-based only, you change your mind when you have access to the OCT data.